So these are the three pieces of literature that I leaned most heavily on for this didactic. Two of the pieces came out around the same time and were written by the same group. So there was a resource document on risk management liability issues. At the same time, practically, I almost want to say it might have been the same article, or it was the article that expanded a little bit, was published as chapter 5 in the book edited by Lori Rainey on integrated care. And so there is actually a chapter on that, but they're very similar. So I would say that I leaned mostly on the resource document, but that chapter is also a good resource. And then a more recent article that looks at ethical and clinical issues and integrated care around patient privacy concerns and electronic records. So some of the issues to concern around liability specifically is what we'll start out with first. So for liability, it really addresses medical malpractice. In order to determine whether or not there is any kind of liability for medical malpractice or negligence, you have 4 things that you really have to look at first. The first of which is duty. If there is no duty, then there is no malpractice, because there was never that initial, that must actually, that's one of those things that must exist in order to then get to the other pieces of it. If there was a duty to the patient, then in order to have liability for malpractice, they'd have to be able to demonstrate a breach of duty, that breach of duty did actually cause whatever the problem was, and there were actual damages sustained. So something bad goes wrong, something goes wrong in the middle of a surgery, but there's no damages, there's no malpractice. There actually has to be all of these pieces. So when we look at what duty means, that's really, do you have a doctor-patient relationship? And in integrated care, sometimes that's not super straightforward. So for your patients that you're the primary provider, obviously you have that doctor-patient relationship. But when it comes to working in an integrated care practice, and you maybe are working with a consulting provider, or maybe there is a direct supervisory relationship, it can get a little bit more foggy. So the simplest form of doctor-patient relationship is the physician and patient both agree to the exam, diagnosis, treatment, prescribing, if everyone's in agreement that we're going to do this. And the longer definition down there is just directly from the Ohio codes, so you see how it's written out in Ohio law. There is a consideration that some courts can look at things a little bit differently and can break it down into things that would actually be considered in a court case, and those details are within those resource documents, but it's a bit more than I think is necessary to go into detail on for this presentation. So the other thing that you have to look at is tiers of liability. So even if you don't necessarily have that duty, or you're trying to figure out where your duty lies, or if there is a doctor-patient relationship, you can also look at, what's the highest risk of liability, and most likely to identify, have a court or somebody else say, yes, you had a duty to that patient, versus the lowest risk. So the highest risk would be supervisory role. And something that's actually referred to in more of the legal terms as respondent superior. And I don't know if I'm saying that right. It's been many years since I've taken Latin, so give me a break on the pronunciation. But if you are in a supervisory role to someone, whatever advice you give them for their patient, you actually are then potentially liable for it. And I've seen this as a supervisor, where anybody that I was the supervisor for, if I was making recommendations, at the end of the day, I was the person who's going to be at the highest level of liability because I was in that position. It also actually extends to the employer as a whole. So the employer of the practicing physician or practicing clinician is actually in a higher tier of liability than the clinician themselves, very often. Middle of the round would be collaborative. So if you are working with someone and you have a collaborative treatment approach, you can have some liability there. It's not always incredibly straightforward. So the biggest recommendation is to look to certain factors to help figure out whether, how much your liability would be. And then consultant role, which again, it's a little bit foggy. I mean, the formal consultation is one thing. There's a higher level of liability or potential to be able to say there's a doctor-patient relationship there than it would be if it was a curbside consult. And then there's gray areas in all of this, that's when we really want to rely on attorneys and people who are more experts at sorting out the gray areas. Formal consultations, so this is where you would have a little bit more potential risk of liability. because it's really occurring when there is a treating physician or clinician of some sort who's asking for the written or verbal opinion of a consulting physician. So you see this in the collaborative care model, where there's a primary care physician who's working with the behaviorist, who's also working then with the consulting psychiatrist. So that consulting psychiatrist, whatever their opinion is, there's a lot more liability there than if you were asking for a curbside consult in some other session or some other format. The formal consultation ends up resulting in the creation of that physician-patient relationship, so therefore establishing duty, and typically occurs through if there's been some type of telephone contact or face-to-face contact between the consultant and the patient. The consultant is typically documenting directly in the patient record. Someone, whether it's the consultant or the consultant's employer, is typically receiving a fee for the consultation. And there may even be medications prescribed as a result of the consultation. So this is all very much what you see in the collaborative care model. But obviously it's not the model that any of us are using or that you see in all integrated care practices. Curbside consultation, while also referred to in the collaborative care model, I think is the thing that we're all much more used to. It's when you happen to be in the hallway or there's something going on and you walk into someone else's office, or even amongst closer friends and or other providers, texting someone with a little scenario and what would I, if they have this level of a number on their lab, should I do this or that? But there's rarely do you know what who the patient is or have any sense of identity of the patient. It really is the informal advice seeking. It's much of kind of what the basis is of Project Echo. This is a group of individuals who are your colleagues who you can ask in a de-identified way for some advice and feedback. There's no face-to-face contact or telephone contact, no direct contact with the patient by the consultant. If there's any documentation, it is certainly not within the patient's record, and there's no compensation. Except maybe when we do bring in chocolate here, but I think that's as close as it gets. So looking at the collaborative care model very explicitly, so the role of the consulting psychiatrist is broken down by Lori Rainey and her colleagues. So about 95% of the patients are curbside. So there's somebody who comes in with depression, they're maybe seeing the behaviorist, and you maybe are giving some information or advice to the behaviorist or the other people on the team in a fairly informal way. About 5% of the patients, there is some limited formal consultation or psychoeducation provided directly to the patient. When it looks at the caseload and where the liability is between the various team members, psychiatrist is in a supervisory role to the behavioralist, whether that's a counselor, social worker, or nurse. So there is a lot more liability there, where the psychiatrists and the PCP are either working in a more consultant equal approach or a more collaborative role. So that PCP is holding much more of the liability. This was shared in that resource document as a sample that you could use if you are actually documenting informal consultation, just as a caveat to put it in there at all times, kind of a CYA type of a thing, which is nice to have. It's good to have examples of things that you could use that have been tested by other providers and practitioners as something that's helped them avoid issues of liability. So they end with tips for risk management if you're concerned about managing any type of liability issues within specifically the collaborative care model, or other similar types of practices. So if you have a contract, really make sure that it very clearly spells out roles and responsibilities. If you have a supervisory relationship with someone, make sure that those are very clearly spelled out so that you have a sense of where the limits are and where some of your protections are. Just making sure that any contract language is very specific. Always referring back to state and federal laws and regulations, whether that's about HIPAA information or what constitutes a doctor-patient relationship, what constitutes a medical malpractice. Sometimes the states are a little bit different. To be cautious when something that seemed informal and a curbside turns into something more and actually looks more formal, and maybe now all of a sudden you're being brought into the room with the patient. So just to be aware that you're now increasing your risk for liability. Effective communication, the hallmark of all of the things that we do in integrated care and team-based care, interprofessional care. We need to have effective communication. So always trying to do that in all of the various means, whatever they are, and making sure to adhere to your profession's ethical guidelines. But like I said, not all integrated care uses the collaborative care model, so there are other things to consider when there's a need for integration of health information across the disciplines and across systems, and there's a need for more systems to actually share that information in a meaningful way. I mean, we're still not quite at a place, unless we're working within a larger healthcare system that has like Epic or a larger integrated record. A lot of us are still trying to figure out how do we share information meaningfully. But when you look at what's out there in terms of what we can do versus what we should do, or maybe what our patients would prefer us to do, there are some differences, and these are things that are worth considering. And I think that we talked a little bit about them last week, and we've certainly talked about them before when it comes to issues around HIPAA and confidentiality. There's the what does the law say versus what do I think is right versus what does the policies say. So keeping all these things in mind, I think, is a helpful way of mitigating risk and liability overall. So from the patient perspective, patients, when surveyed, prefer to have control over who has access to what, particularly mental health and substance use disorder treatment records. There is a lot of concern about stigma among non-mental health providers. If the concern that if you have a fully integrated system and your podiatrist looks into your mental health records, that now you might face some type of different kind of treatment from those other providers. We know that diagnostic overshadowing does happen, and that stigma around mental health and substance use disorders still exists. So I can understand the concerns. Within electronic medical records, there is often, if you have an integrated system, something like Epic, even if those records are a little bit more kind of tapered off, physicians can what's called break the glass to be able to then read the more detailed information. And realistically, most medical record systems do not offer the patients the option to say what can be released and to whom. And even if patients try to express such a concern, there is no legal obligation to honor those preferences. And I'm not sure that patients really know that. Legal guidelines, so that's another thing that we have to consider, because there are what the patient prefers, but sometimes we can't fully go on that for a lot of reasons. On the left is something that was stated in the HIPAA privacy rule summary, and that we've talked about before, and I feel like Doug's talked about before the various times we talk about HIPAA, but the intention of HIPAA's privacy rule was to actually help the flow of protected health information about shared patients flow more easily. There is an expectation that a good faith effort has been put out there to notify the patient of what the privacy practices are. Legal guidelines do typically, and this is more specifically HIPAA, we all know that substance use treatment disorder records under 42 CFR Part 2 are that's a little bit of a different animal. But HIPAA allows for treating providers to exchange most mental health records without significant patient consent or specific patient consent. There doesn't have to be written consent. And it does not preclude providers from taking additional steps to ensure privacy and confidentiality of mental health information. Psychotherapy notes are always the exception to this, and we'll come back to that in a second. So the APA, when it comes to professional standards, because that would be the other thing to look at, the APA actually recommends the following types of information be held outside of the formal medical record. And these are the things that would be specific to psychotherapy notes. So like I've mentioned before, and we've talked about before in echo sessions and otherwise, is that psychotherapy notes do require, in the state of Ohio, an extra signed specific consent, just as substance use treatment disorder records do. But those are the only portion of the mental health record that require the extra notes or the extra permissions. The thing is that most people think that psychotherapy notes are the progress note that a therapist writes in the record, and that's just not true. What is put into an electronic record is really for insurance purposes. And to be able to demonstrate that you are actually working on a goal that is tied to a diagnosis and whether or not the person is making progress. So these things are actually what would be psychotherapy notes or process notes that should never land in the official record. And there's lots of things that you should do to protect these, but anything that's super intimate, personal content or facts. When I was in practice, one of the things that I would do is I had a separate notebook that included some of the details of individuals' trauma, whether that was the name of perpetrators or the timeline or history of trauma issues. Because what I didn't want to do is, if I hadn't seen somebody in a month or it's the second session and they've spent a lot of time going through this long, detailed trauma timeline, like, so wait, was that the first guy that raped you or the second one? Trying to come from a trauma-informed standpoint, you really can't do that. So I would keep that separate, never with any names attached, just kind of my own little system of knowing who was who, so that I didn't have to do anything that was re-traumatizing. And frankly, nobody from the billing office, if they happen to read over the note, needs to know those details. They're very sensitive. Any details about fantasies or dreams, the process interactions, sensitive information about the other people in the patient's life. So, their family members' names, or something that maybe is going on with a family member, stuff that you need to remember so that you can have a bigger picture, but not necessarily something that you ever want to then get pulled into, an insurance record or other issues. Because if you're talking about a family member that the insurance happens to cover all of them, all of a sudden now you've got insurance being like, hey, we didn't know that Johnny also had this medical condition, which is definitely a problem with insurance dictating what treatment happens. But your formulations, hypotheses, speculations, things that really, don't actually relate to the formal process of treatment and what you're getting paid for, and topics or themes discussed. So none of these things really should land in the medical record. You probably want to have them, but they're not really appropriate, particularly for an electronic record. And these would be the things that are considered psychotherapy notes, that you need the additional promise or the additional okay from the patients to release to other providers. And that's about where we are. So there's an opportunity for us to there's a couple cases that were at the end of the one article, and I put in a bit of that, but we don't necessarily have to go to it now. So I'll save that and ask Jamie to stop